to say tricky topic, which is rarely discussed in our meetings, the second primary tumor in oral cavity cancers. And believe me, the one name which came to all of our mind was to ask and request Dr. Shaha to talk about the second primary tumor. So over to Dr. Shaha. We have formed some questions for you, so you can talk the way you want to do it. Please.
Thank you very much, Rajendra. I hope everybody can hear me and see me.
Yes, sir.
Let me just start a little bit preamble and continuation of what Alok said. The times have changed quite a bit. Our philosophy of surgery has changed. More important than that, I would like to add, the philosophy of life has changed. We are questioning ourselves, the basic principle of life, why we were born, where we are going, and how we are going to end our life. Is it going to be me getting involved in the corona? And is that going to be my future? I think this fear always remains. And I don't know how long we'll live with this fear. We are taking utmost precautions, both in the house, outside the house, in the hospital. I must give credit to healthcare workers for taking care of both corona patients and non-corona patients. Things are getting back to, I wouldn't say normality, but I think we're doing more and more, especially at Memorial, cancer-related surgeries. There was a time when we pushed the surgery for as much as possible. So Rajendra has given me a difficult subject. This has probably nothing to do with COVID. It is totally an independent subject. I had a lot of interest in this subject in the earlier years. We wrote quite a few papers on multicentricity, synchronicity, and metachronicity of the head and neck cancer. That was one of my favorite subject when I was working at VA Hospital. So let me answer some of the questions that he has raised, and they are already on the screen. But before I start, I think the two important issues when we talk about multicentric cancer or second primary, etc., is understanding of the field cancerization. I think that is very important. Credit goes to Danley Slaughter back in 1953. Imagine, almost more than 70 years back. He wrote a paper in Cancer, which was probably one of the landmark papers explaining the field cancerization. And why is there concern about field cancerization? The etiological agent, whether you consider tobacco, alcohol, acts on the entire upper aerodigestive tract. And the possibility of having synchronous second primary means a patient presents with tongue cancer, you investigate and find esophageal cancer, was in the range of 10 to 15%, or maybe little more than that. We published data from VA Hospital. Our incidence was 13%. Synchronous primary. And at that time, there was a lot of discussion about the pan endoscopy, esophagoscopy, bronchoscopy. There was a lot of interest in triple endoscopy or pan endoscopy. So the Danley Slaughter's paper is very interesting. And I think we should know that field cancerization is a normal phenomenon in the head and neck. The second issue that we need to understand very well is what is the primary and what is a recurrent tumor and what is a second primary. To understand the philosophy of second primary, we need to go back to 1932 and a paper published by Warren and Gates. And if you go into Google, you'll find it right away. If you put the word Warren and Gates, you'll find the information right away. And they came up with some criteria which are very important. So what is the second primary? The tumor away from the previous tumor. Obviously, if you have cancer on the right side of the tongue and now you have tumor on the left side, or you have cancer in the tongue and now you have cancer in the esophagus, that's obviously a second primary. What is the gap between the initial tumor and the second primary? If the time lag is very short, it is more likely we're dealing with recurrent cancer than the second primary. Now remember, there is a principle in surgery. I never get recurrences. I only get second primaries. And I think we need to be very sure and understand the first surgical intervention, how big the tumor was. And we know as surgeons that this tumor is going to recur. Whatever happens in next 12 to 18 months, that is not a second primary, that is a recurrent tumor. Now, there are many papers in the cancer of the larynx where the tumor may be on the one side and now comes on the other side. And that becomes philosophical. Is this a second primary, or is this the tumor that was missed first time? I think we need to keep this in mind when we talk about the second primaries. And the last factor that Warren gets published is the pathology. If the initial tumor was squamous cell carcinoma and now we have adenocarcinoma, we know this is a separate primary. And one of the important points they also added was, if there is an in situ component in the new tumor, it is more likely to be second primary than recurrent tumor. The recurrent tumor is generally infiltrative. It's more submucosal. It's more infiltrative. So if you see the in situ component, again, these are the criteria which were described. We as surgeons need to realize that we understand the initial extent of the disease, and based on that, we would be able to tell whether this is a second primary or a recurrent cancer. Keep in mind, the recurrence in the early stage, stage 1 and 2, is very small, about maybe less than 20%. While stage 3 and 4, the recurrent cancer is going to be seen in almost 50 to 60%. If we keep that in mind and the time duration, if somebody has tongue cancer now and recurs or comes with a cancer on the other side, say 5 years later, you are more likely to think this is second primary than the recurrent cancer. Now, initially, we used to define that the recurrence may occur anywhere between 18 months to 24 months. And that's why our limit of careful or critical evaluation was almost 2 to 3 years. Now, things have changed quite a bit. And with the of our treatment, including radical surgery, reconstruction, and post-op radiation or chemoradiation therapy, we recurrence as late as 4 to 5 years. So don't call this second primary because it happened in 4 years. Keep in mind the risk of recurrence. So I already mentioned about the criteria and the pathogenesis. I think we do understand the field cancerization, Warren and Gates criteria. Those are very important. These are two important papers. And again, as I said, look into the Google or the PubMed and you'll find the information. So the next question, if you can go to the next slide.
Yeah. Next slide.
The next question that was asked was, what is the optimum investigation? Again,
go to the next slide.
Yeah, I think he did. Yeah, we are in the second slide. That's fine. So what are the optimum investigation? Again, I'm going to go back to the primary tumor, the same investigation, critical clinical evaluation. I think the surgeon's fingers will tell us more than anything else. And this is one area where if you cannot evaluate the tumor, you may have to bring the patient to the operating room for better evaluation. I think it is very important. Examination under anesthesia is very important in these patients. I think this is very important to realize about the evaluation of the tumor. The next one is, what are the margins of resection? And again, the margins of resection will depend on the extent of the disease. Keep in mind, the second primaries may remain more in the submucosal area or even the recurrent tumors. And you may not be able to appreciate the extent of the disease. The margins of resection, I'm not going to say 1 centimeter, 2 centimeters. That's what we talk about the oral cancers very commonly. But the margins of resection should be wide and handsome. If this, let's say this is a recurrent tumor, this is the only chance you have in controlling this cancer. There is no other chance. And I think it's very important to make sure that we resect this tumor satisfactorily. The reconstruction is very important. Majority of these patients who require radical resection will require appropriate reconstruction. Now, I'm not going to go in the details of the COVID era, but majority of these patients will require free flap reconstruction. I think it's very important to realize the primary closure, either in the second primary or in the recurrent tumor, may be very difficult. And as a surgeon, again, the reconstruction will depend upon the extent of the defect and the need for appropriate reconstruction to bring the patient back to the normal life, or reconstruction in such a way that the functional rehabilitation is well maintained. The next question is management of the neck. Before we go to the management of the neck, the preoperative evaluation, either whatever test you want to use, ultrasound, CAT scan, MRI, PET scan, is very critical. Clinical evaluation may be difficult when the patient had previous treatment, either with surgery or with radiation therapy, or whether this is a second primary tumor. Management of the, again, I'm going to go back. This is the last surgical procedure the patient is going to have. And you do the best, whether it is second primary or recurrent cancer, you offer the best you can. So the management of the neck, again, will depend upon the local extent of the disease and the reconstructive technique. If you're going to use a microvascular flap, you're going to open the neck. And doing a modified neck dissection would be a standard approach in most of these patients. The next question is, what about adjuvant treatment? Again, let's go back to the extent of the disease. And the same principle, if it is an early recurrent tumor, means small recurrent tumor, you can dissect it and probably not use further adjuvant treatment. But it will again depend upon the margins of excision, perineural invasion, lymphovascular invasion, the depth of the tumor. These are some of the factors which will come in the picture. The positive margins and the node positivity with extranodal extension are the main concerns for which we have got a lot of data about using post-op chemoradiation therapy. The next issue is re-radiation. Can we re-radiate patients? I think, at one time, let's say about maybe 15, 20 years back, radiation was given only once. Now we have probably become bolder, or more importantly, the radiation oncologists have understood the biology of second radiation. If you have done a reconstruction, let's say with a PEC myofibrillar flap or free flap, the entire area which was affected by radiation is gone. And you could easily consider re-radiation for better control of the disease. Are we taking major risk by re-radiation? Absolutely, yes. There may be necrosis of the skin, carotid exposure. But keep in mind, when the patients have aggressive recurrent disease or second primary tumor, and you want to, you have already done a satisfactory resection, but you are concerned about the margins, you are concerned about the future recurrences, which may be fatal, I think re-radiation is a good option. Now, if you talk to the radiation oncologists, they will evaluate the initial extent of the radiation. What were the portals? Keep in mind, it is quite likely that the second primary tumor or the tumor that you are dealing with is outside the field of previous radiation. And this is very common with early larynx cancer or oral cancer. Most of the time, the hypopharynx and the larynx is not irradiated for oral cavity cancer, unless there was extensive nodal disease. So the re-radiation, and you will see a lot of literature on this subject. I think initially it started in the University of Chicago with Wexelbaum and other people in their group using or considering re-radiation. Yes, there were complications, but it was soon apparent to everybody that a fair number of these patients can be re-radiated. Yes, there is a concern about skin necrosis. There is a major concern about osteoradionecrosis. I don't think we have good data to say the complications of re-radiation, but we have seen fair number of complications, and that's why we are very concerned. And I want to go back to the same philosophy. All these patients should be, and I would say must be, discussed in the multidisciplinary team to have the input from the surgeon, medical oncologist, the reconstructive surgeon, and radiation oncologist. It is amazing how much we have learned in last 2 decades talking to each other and presenting these cases in the tumor board. In many parts of the world, patients with advanced head and neck cancer are not treated unless they are discussed in the multidisciplinary team, MDT, or multidisciplinary groups, whatever you want to call it, but that is very important. And I think the radiation oncologist can help us decide whether the second course of radiation is appropriate, can the patient handle it. Evaluating the tumor tissue or the skin is quite important. If the skin is indurated and there is enormous telangiectasia, you know that the second course of radiation is going to be very difficult for the patient to handle. Okay, can we go to the next slide? Okay, there are a few other questions that Rajendra has put for me. The frequency and the duration. I think that, as I mentioned in the beginning, the multicentricity, synchronicity, and metachronicity was seen in about 15 to 17% of the patients. There are quite a few papers at that time. This was back in, I would say, early 90s about these field cancerization issues. And the overall incidence was about, I would say, 15 to 20%. If you put the second primary in more proper perspective, I would say about 15%. We talked about the most of the investigation. The question about chemo prevention, I think this is an interesting question. If I can summarize only one thing, none of the chemo preventive agents have shown any major impact. At Memorial, Dr. Shah did a very nice study on 13-cis retinoic acid. This was back when I was a fellow, back in 1982-83. And this was published showing that there is some, during the time you're treating with cis retinoic acid, but eventually there was no impact on that. The tumor came back, or the tumor stayed just the way. Ki Hong did a remarkable study from MD Anderson, and again came to the same conclusion that none of these chemopreventive agents had any major impact on them. Keep in mind, quite a few of these chemopreventive agents may have side effects and complications, and something that we need to keep in mind. And last couple of minutes, I want to address the issue which Rajendra has already put in the slide, the tobacco and alcohol cessation. I think these two are very important aspects of management of head and neck cancer and follow-up of head and neck cancer. As a matter of fact, in our institution, the day patient comes in the Memorial, there is the enormous evaluation from the nursing staff, from the medical staff, and from the ancillary staff for their smoking and alcohol. We have a whole smoking cessation program, and they have done a remarkable job in trying to help these patients to stop smoking and alcohol. It is not easy, believe me. But if we make genuine efforts to stop smoking and alcohol, we're going to see the reduction of second primary, and I'm not going to say reduction of recurrence, but probably some effect on the recurrent tumors. And I think this is very, very important. As a matter of fact, many of you know Vikram. He wrote a paper. He was a radiation oncologist at Memorial, and he wrote a paper that there was a big difference in the patients who continued to smoke and drink and those who stopped. The incidence of second primary or recurrent tumor, etc., was much low in the patients who stopped smoking and alcohol. And our goal as a surgeon does not end by taking care of the patients with radical surgery, chemo, radiation, but our goal is also to advise them to stop smoking and alcohol. And I think we have seen the effects of that. As a matter of fact, in the United States, since the Surgeon General announced about smoking hazard, and I think I would say the smoking cessation has taken a major impact in the United States, and we are seeing reduction of cancers of the oral cavity. We are seeing less laryngeal cancers, hypopharyngeal cancer, and lung cancers. Credit goes to the people who took this in their hand, fighting with the tobacco group and coming up with the solution of stop smoking. And that extended not only in the airline, public life, but in every part of our life. So I think this prevention is very important. Again, the subject of second primary and the recurrent cancer is very interesting. We need to keep our eyes open and discuss the case with your colleagues and in the multidisciplinary tumor board, where we will learn more from each other. Be safe, God bless, and I hope the future is bright. Thank you,
Dr. Shah. But I have got a couple of follow-up questions on you. So,
sure.
Why is it really important to know whether this is a second primary or a recurrent cancer? And if yes, is there a difference in the prognosis?
Yes. I think that if the second primary is truly a second primary, you don't have to look at it as a second primary. You can say that this is a second tumor and treat it the same way as you want.
Okay. And do you always
so let's say the patient has a lip cancer and now has a soft palate cancer. The outcome is going to be the same. While if it is a recurrent cancer, believe me, they are not going to do well.
One of the questions from the audience, from the delegates, is what is the role of PET scan? Do you always do a PET scan when you are evaluating a second primary tumor?
Okay, so I'm going to make it very simple, casual answer. There is nothing always. In the United States, we like to do the PET scan. It is available. It is easy. The insurance companies pay for it, especially when we say that the recurrent cancer or staging. Is it a must? No. Clinical evaluation is very critical, added with appropriate imaging studies. And that's why I'm using the word very carefully. Okay. Appropriate imaging studies in your institution. The PET scan is good to evaluate the rest of the body, absolutely. It is very good to evaluate the extent of the disease, but is it a must? No.
So when we talk about second primary tumor in the oral cavity itself, usually the neck would have been addressed in the first time.
Correct.
So if suppose a supraomoid neck dissection was done, would you then do a completion of the neck dissection?
No.
If it is N0, or if there are positive nodes on the same side, obviously we'll do a ipsilateral completion neck dissection. But then what do you do with the opposite neck?
Right. That's a good question. Again, preoperative evaluation is very important. If there is a bulky disease on one side, recurrent tumor, bulky disease, I may consider a selective node dissection on the other side. But if the opposite side is N0 and the ipsilateral side is also N0, I would not do a completion neck dissection. I would not go on the other side.
So it will depend if the nodes are bulky or not, then you'll decide accordingly.
Correct. If let's say there is a bulky disease on one side, you do expect that there may be microscopic disease on the other side, which you cannot evaluate with any of the imaging. And since the incision and everything is going to be the same, you're going to add another 45 minutes. I would do a selective node dissection on the other side.
The classical teaching that is done is that if the tumor occurs after 3 years of the first primary, it is usually considered as a second primary. Or if the distance between the first primary lesion and the second primary tumor is more than 2 centimeters, it is considered as a second primary tumor in the oral cavity. Does it still hold true, or
I would say it is opportunistic, popularized by surgeons. I hope, 2 centimeter was an imaginary description. Yeah. But let's say there is a cancer of the tongue and now it is in the submucosal area, going on the other side, crossing the midline. That's the same recurrent cancer. Again, you mentioned about 3 years time. I'm not very convinced that 3 years is a cutoff. That's why I use the word the opportunistic surgeons. And I said right in my talk that I don't get recurrences, I get second primaries. So I think the whole idea of 3 years is need to be changed. It's the location of the tumor. Knowing the initial extent of the disease is more important. Go ahead.
What is your take on the radiation-induced second primary tumor proposal?
Yeah. I think they do occur. The pathology is quite different. Generally, they are not squamous cell carcinomas. They are generally sarcomatoid tumors. And under the microscope, the pathologist will be able to tell this is not a causal primary. This looks like radiation-induced a tumor. And we used to have one of the finest pathologists, Andy Hughes, and he would tell this is a radiation-induced tumor, or most of those are sarcomas.
Is there a way to
They're
predict?
not generally in the location where the primary was resected. They're generally in different areas.
Yeah. Is there a way to predict a second primary tumor? Any genetic or molecular test that you can do on a field cancerization, submucous fibrosis patient or something?
Yeah, some work has been done at Johns Hopkins. I don't think that work has been carried out. It's a prohibitively costly affair, and more important than that, the information you get is not clinically helpful to manage the patients. So yes, you can do the molecular testing and try to prove. The in situ component will tell you that this is a second primary. But is it going to change? Some people have done the molecular testing between the oral cancer and the lung lesion to see if this is a metastatic or second primary. I'm not sure it is going to help much in future.
We have one question, I think, from Sharad. You want to ask something? And Arnab?
Yeah, my question was, see, the prognosis of a recurrence and the prognosis of a second primary definitely differ. So
Correct.
do we have to break our head trying to differentiate between the two, especially because should we be a little more aggressive if it's a recurrence? Then
we should be always aggressive for every cancer.
No, little more aggressive
so
than
for recurrence, yes. And if there is a second primary, again, these are more like we are trying to define the disease based on the extent of the tumor. And that's why I use the analogy. If the tumor is in the larynx and now something is in the mouth, it's totally different. You're going to treat it not as a recurrent tumor, you're going to treat it as a second primary. If it is the oral cavity cancer which has recurred, I hate to call it second primary. I would call it local recurrence, unless one was in the left and the other was in the base of the tongue or in the soft hard palate. Should we be aggressive? Absolutely yes. Even for the second primary, would I be aggressive? I would put it in the same format as you are treating initial oral cavity cancer or any head and neck cancer.
Any thoughts on curcumin as a chemopreventive agent?
I'm not. My conclusion is it is not very helpful. I would not recommend it as a choice of management. Should you live a healthy life? Yes. I'm not going to say anything. But more than that, I would go back to what I said, prevention by stopping smoking and alcohol and any other habits, the chewing tobacco. And I think when we see an Indian patient, we spend more time with them to stop gutka and tobacco and pan.
Yeah, Dr. Okan, I just want to ask something.
Yeah, please go ahead.
Yeah, another wonderful talk, really enjoyed. Just want to ask you, how much HPV-related head and neck cancer do you see? I don't know whether you covered this topic because I lost the signal in between. So, Dr. Shah,
I didn't get the question. Can you repeat it? I didn't get the question.
Do you see a lot of HPV-related?
Oh, absolutely.
Do you see a lot of HPV-related?
Oh, yes. I didn't get that word HPV. I would say, if I can use the numbers, we see less and less larynx cancer. We see less and less hypopharyngeal cancer. Partial laryngectomy is a forgotten operation. Oral cavity cancer, we are seeing less and less. What we are seeing now is HPV-related oropharyngeal cancer, the tonsil, the base of the tongue. I think I would say If you take 100 squamous cell cancer at Memorial, I'm talking about squamous cell cancer, about 40 are HPV-related oropharyngeal cancers. And we have an entire group of multidisciplinary team discussing management of oropharyngeal cancer. We don't treat them individually, because what was happening was, without discussion in the MDT, multidisciplinary group, the patients were getting differing opinions. So now we give them one opinion as a group. And that has become very, very helpful. Every oropharyngeal tumor or an unknown primary gets HPV tested.
So last question on surveillance and the post-operative follow-up.
Yeah.
The question was from the audience, how long do you follow up these patients, at what intervals, and apart from clinical examination of the oral cavity, what specific investigations at each visit do you advise for the patient?
That's a great question. It's a whole topic by itself, but let me just summarize. When I was a fellow, we used to see these patients every month. Can you believe that? And the clinic would be full of follow-up patients. We would take about 2 minutes and say, okay, your tongue is fine, I don't feel anything, go home. But over a period of time, we realized that that was too much. I think it was not cost effective. So we started seeing them every 3 months, and we were quite happy with that. So initially, first year, I would see them every 3 months. Second year, every 4 months. And then onwards, every 6 months. After 5 years, you can send the patient to the primary care, or tell the patient that you are more than welcome to come and see me once a year. We have got surveillance clinics, which are run by the nurse practitioners. You can send the patient to them.
And
what investigations we should, what investigation? I think, again, I'm going to go back to my first sentence. Clinical evaluation, most critical. If you cannot evaluate the issue, and there is a lot of scarring and fibrosis, or there is a concern in your heart, then get the imaging studies. And the best imaging study for me is a CT scan, because I can interpret it very easily. Obviously, if there is a major concern about the neck or the primary or second primary, get a PET scan. But clinical evaluation, feeling the area, if you cannot feel the base of the tongue, obviously, you're going to need appropriate imaging. MRI is the best test, followed by PET scan.
I think it was great talking to you, Dr. Shah. Probably we can end this session here and over to Atul. You want to say something?
I have one question. If some patient have a primary T1 or T2 lesion and following after 2 years develop a second lesion, and patient was T2 or T1 N0 and did not receive any radiation, again the recurrent tumor, or we should say second primary, whatever, and it is again a T2 lesion. So should we add radiation this time because it is a recurrent tumor or recurred within 18 months or something like that?
Again, I'm going to repeat what I said. Radical surgery is the best choice. Number one, appropriate reconstruction. If there is a serious concern in the mind of the surgeon, based on the clinical extent of the disease or the final pathology report, I would consider adding adjuvant radiation therapy second time. But keep in mind.
No, first time, sir. First time patient has not received any radiation. It was a T1 lesion. Now recurred within 20 months. Should we add radiation despite having a T1 lesion? T1.
Okay, there is a small recurrence.
Yeah.
Am I correct?
Yes.
And you had done surgery.
Yeah.
You had done the surgery.
Yeah.
Good margins. No lymphovascular invasion. I would hold off radiation. Unless that there are the concerns about the depth of the lesion. Again, the same principles. And you go back and find out why this tumor recurred. Probably it was underestimation of the extent of the disease. Remember, majority of the recurrences occur. Number one, underestimation of the extent of the disease. Number two, underestimation of the surgical intervention. And number three, underestimation of the pathology, not evaluating the borders, the tumor islands, very important. If the patient has a tongue cancer and a tumor island, the possibility of recurrence is very high. So if you put that in perspective, it's a recurrent T1 cancer is managed in the same way as a primary tumor, but more concerned that the further recurrences are quite likely.
Sir, we missed one thing during this talk from your side. That is Dr. Shah's aphorism.
Next time.
Okay. So I think we'll end this session. Thank you very much again. If time permits, we'll have again a question answer session at the end. Dr.
I'll be
Atul,
on. I'll be here.
Atul, you can go to the third session.
Thank you, Dr. Saha and Dr. Toprani, for very informative talk, and it will be helpful for all of us in future management of second primary or the recurrent cancer. And for third talk, we have a Dr. Kumar Pravas from Tata Memorial Hospital. He is head of medical oncology there. And to moderate this session, we have none other than Dr. S.V.S. Dev.